Hi, everyone. We're going to get started in just a few seconds. We're going to let everyone trickle in right now, and then we'll get started in less than a minute. Thank you so much for being here. Hi, good afternoon or good morning, depending on what part of the country you are joining us from today. Thank you so much for being here and welcome to the webinar on understanding HRSA's new stillbirth outcome measure. It is an honor to have Dr. Shirley Payne here with us today. She is with HRSA. Her title is Director of the Division of State and Community Health, Maternal and Child Health Bureau from HRSA. And also to have Dr. Karian Uesugi, who is also from HRSA. She's a health scientist, Division of State and Community Health, Maternal and Child Health Bureau from HRSA. And I'm Emily Price, the CEO of Healthy Birthday Inc., a leading stillbirth prevention organization in the United States. My greatest title is mom, however, and I have a son who was saved by the proven stillbirth prevention program, Count the Kicks, 14 years ago. Today's meeting will be recorded and shared back with all of you, along with today's slides. Throughout our time for today, please feel free to send in questions in the Q&A function. And at the end, we will take time to answer as many questions as we can. Any questions that we are not able to get to, they will be addressed and answered in that follow-up email that will be sent to you early next week. So before I turn it over to our HRSA speakers, I want to go ahead and level set that stillbirth is a public health crisis in this country. More than 21,000 babies are stillborn each year in the US. This is approximately 7 times the number of those lost to sudden, unexpected infant death. And this is what the crisis looks like in this country. 1 out of every 175 pregnancies ends in stillbirth in America. This is according to CDC and National Vital Statistics. And racial disparities persist. For Native Hawaiian or other Pacific Islander pregnancies, 1 out of every 101 pregnancies ends in stillbirth. It is the same for Black pregnancies. 1 out of every 101 Black pregnancies ends in stillbirth, which is defined as the loss of a baby at about 20 weeks or greater during pregnancy. For American Indian or Alaska Native, 1 out of every 133 pregnancies ends in stillbirth, and their rate, by the way, is on the rise. For white pregnancies, 1 out of every 206 pregnancies ends in stillbirth. For Hispanic pregnancies, it's 1 out of every 207 rather. And for Asian pregnancies, it's 1 out of every 253 pregnancies end in stillbirth. And so I want to share just how grateful we are that HRSA acted thoughtfully and quickly when advocates across the country asked that HRSA create an outcome measure dedicated solely to stillbirth. The advocates, thousands of lost families across the country, believe that in order to make improvements in the public health crisis of stillbirth, we must be able to have a proper way to track and measure progress and implement highly effective programs to save lives. We were floored when Dr. Michael Warren called us in September and said, "We heard you and we created an outcome measure only 3 months after advocates started asking for the change." This is true leadership and the fast action from Dr. Warren and his team. You can read about this by scanning the QR code on the screen and scroll to page 91. It is a true honor to introduce you to Dr. Shirley Payne, who helped make this happen, and Dr. Karian Uesugi of HRSA, who will now explain what this outcome measure means for you. I'm going to go ahead and stop so that they may also share their screen and their slides now. Great to see you, and thank you so much for being here.
Yes, thank you, Emily. So great to be here with you all. Any opportunity that we do have just to talk about the work that we get to do at the Maternal and Child Health Bureau every day, and especially within our Division of State Community Health with the Title V Block Grant program. We are certainly excited and always happy to do so. And I'm grateful that I'm here with my colleague, Dr. Karian Uesugi. So we're hoping that the information that we provide to you today is beneficial and helpful, and looking forward to being being able to answer any questions that you may have today and in the future. Next slide, please, Carrie Ann. So in thinking about, just we're going to level set just a bit here when we, in thinking about the Title V block grant itself. Now, having been established in 1935, when the Congress passed the Social Security Act, Title V block grant is the nation's oldest federal and state partnership. Its continued purpose, even since then, is to continue to improve the health of the nation's mothers, children, and families, including children with special health care needs. Making sure that the states do have and jurisdictions have that flexibility that they need in order to respond to the unique needs of their population. And I want to also be very intentional to say, we do refer to it as the block grant as a partnership to convey both that certainly we as the federal government are putting in lots of time, resources, and really thought and intentional thought into thinking about how we are addressing needs. But we also know that the state is doing that as well and putting in their resources for us too. And so together, it truly is a partnership where we're working to than we can alone as the federal government and as the state government, which we also know trickles down to local governments and communities, be that local health departments or other community-based organizations as well. So a few key I say aspects of the grant is that when we think about improving and what the work does look like, I'll get into a few more specifics here, but our biggest thing is emphasizing that accountability of the block grant. And so you'll hear Dr. Usugi come in and talk about, in general, our performance measure framework before we get into talking a little bit more about the Stillbirth National Outcome Measure that we have developed and created and incorporated into the block grant performance measurement. But the biggest thing too is that flexibility for the states. We recognize that, we have 59 states and jurisdictions, and each, you talk to one Title V program, you have talked to one Title V program. And so that flexibility, them being able to do their needs assessment and to being able to assess where they are and being able to select performance measures and other outcome measures that they feel are necessary and needed to address their population. Next slide. For our guidance, the biggest thing for us is, we like to have guiding principles. And what does that look like? How can all of the work that we get to do every day, what does that roll up to be? What does that look like? And for us, there are 4 guiding principles that we have. You heard me talk a bit about the accountability there. So that second one there of data-driven program and performance accountability. We do recognize as a team that, yes, data is a large part, a big piece of that. Certainly that's quantitative data, but we are concerned too about the qualitative data that comes along with what we have. But we have developed, what we believe is a robust 3-tiered system when it comes to our accountability and measurements, our performance measure framework. Again, we'll have more about that as well. We also, when we think about this grant, it's delivering the Title V services in a public health service model. That means it's a lot of population health. And though the grants go directly to state and jurisdictional, so that health entity, which is usually that public health agency, but our goal is for the broader reach and what that looks like. We also family and community partnership. It really is at the heart of the work that we get to do every single day. And we want to listen to families. We want to listen to self-advocates. We want to be able to listen to the community because that's where the needs are. We firmly believe, we talk about it a lot with children with special health care needs of the, nothing for us without us. And we truly believe that across all of the populations that we are able to address within our maternal and child health Title V block grant. Also health equity, and which is newer, we just had an update to our guidance and which just got our OMB approval, so our Office of Management and Budget approval at the end of December of last year. But, we wanted to add health equity as a pillar there, recognizing that it is important. And that, again, as we think about addressing unique needs, health equity is right at the heart of that. And we're wanting to make sure that that every, pregnant person, every mother, child, children with special health care needs, family is able to reach their full potential. Next slide, please. Title V is big, and it could be for, for folks that are just getting to know it and learning it. Again, we continue to learn, new things every day as we hear feedback and we get to hear from the community. We get to hear from states and stakeholders and partners about all the wonderful work that is happening. It can be, difficult to understand because it is so vast and it is so broad. But I love this image, Dr. Carrie-Ann Iguasugi, and thinking through with this and conceptualizing kind of this diagram. It really is the crux of what it is that we do when it comes to Title V. And our biggest piece is certainly there is funding there that goes to states and that gets supported. But we think about like being a leader in the maternal and child health space and how we are working intentionally to partner. But a lot of that is being the convener and convening. So whether Title V is the lead or it may not be the lead and someone else is there, that we want to make sure that Title V is at the table, but kind of that being in the know and knowing all things of what is happening and being able to provide that expertise at the table, and then ensuring that they are not only, leveraging all that is happening in their state, whether it be federal funding, non-federal funding, or other programs that are happening, that not even funding is not even related to that, but that coordination and that collaboration. We want to make sure that Title V is right there at the table. Next slide, please. All of that together, when we think, about the block and the reach that the block has, we're very, as we get in the reports and annual applications, every year from states, we pull all of that together. We take all the data that we get and that we see. So from our most recent reporting year, so in fiscal year 2022, which is the most recent date of data that we have, the Title V MCH Services Block Grant helped provide services for an estimated 61 million people. And so that includes 93% of all pregnant women, 99% of infants, and 61% of all children nationwide, including children with special health care needs. So we're really excited about the reach that we have. We certainly are always looking for the ways that we can enhance and continue to improve and shape what it is that we do with the block grant. But we're very excited and we're very happy with the place, that we are, but certainly continuing to think through more opportunities and how can we enhance, and certainly Stillbirth has been one of those. Next slide, please. And now it's my pleasure to turn it over to my colleague, Dr. Carrie-Ann Iguasugi, that will talk a bit more about our performance measure framework and get into some of that nitty-gritty and the details around the Stillbirth National Outcome Measure. Carrie-Ann?
Thanks, Dr. Payne. I want to start briefly by going over our Title V performance measure framework to level set a bit. This was developed for the Title V transformation in 2015, and we have not changed the framework in this iteration of the new guidance. It is based on the evaluation logic model. So you can see sort of common terms if you're familiar with logic models on the bottom here. It is a three-tiered system of measures. Starting on the right are the more distal, long-term maternal and child health outcomes that we seek to improve. These are our North Stars. These are our national outcome measures. In the middle here, you have our national performance measures, and these are the short and medium-term outcomes in the logic model that can be impacted by Title V activities at the state level. Each NPM or national performance measure is associated with one or more national outcome measures. The NPMs that we have are population-based state level measures. On the left are the outputs or short-term outcomes of the evidence-based or informed strategies that Title V is implementing. And these are called evidence-based or informed strategy measures, or more briefly, ESMs. They directly measure what Title V is doing. So with a little bit of that understanding of what our performance measure framework looks like, I'm going to dive into the national outcome measures. We have a lot of national outcome measures, many covering the entire spectrum for pregnant women, to mothers, infants, and children, all the way up to age 21, essentially. The ones that are on this slide are just our national outcome measures that focus on maternal and infant health. And we added 3 with this new guidance, and they're sort of glowing. The 2 on the top are, we added women's health status, which is analogous to our current national outcome measure around children's health status. And then we also added postpartum anxiety, sort of in parallel with postpartum depression. And in the middle row, you can see that we added the stillbirth outcome measure. We have had a long-standing measure for outcome measure on perinatal mortality, as specified in our previous guidances. So we had been reporting similar data that included some late fetal deaths, but we did not specifically have a measure on stillbirth mortality, and therefore we now have that as a national outcome measure. So this is just very specific what you will find. This is what we are reporting. This is what we call our detail sheet for the outcome measure. The title is stillbirth rate per 1,000 live births plus fetal deaths. The numerator, or what's on top, is the number of fetal deaths at 20 weeks or more gestation. The denominator is the number of live births plus fetal deaths. This is a very standard definition. Our data source is the National Vital Statistics System, which is available through CDC Wonder. So all the data that Emily was showing you at the beginning of this webinar is the same data that we will be presenting for our Title V reporting. A unique feature of our performance measures and outcome measures through Title V is that we provide population-based state-level data for all of our measures, and they have to come from federally available data sources. So we do not directly collect our outcome measures or state or performance measures. We report data that comes to us from other federally available data sources. So the data source here is from CDC, the National Vital Statistics System. We also put on our detail sheets how our measures might align with Healthy People 2030 objectives. And in this case, our stillbirth national outcome measure is identical to the Maternal and Infant and Child Health, or MICH 01 objective, reduce the rate of fetal deaths at 20 or more weeks gestation. So we put the Healthy People 2030 objective there to help align our measures, our Sentinel measures, with sort of other federal and national priority areas. So just to give you some facts about what does it mean to have, what does a national outcome measure do? They are seminal indicators of health for the MCH population and are measures of preventable morbidity, mortality, health status, and quality of life that we seek to improve over time. Like as I said, these are our North Stars. States do not select their national outcome measures. All national outcome measures, or NOMs, are reported each year for every state. States do not set targets for the national outcome measures. As I said, we provide the Healthy People 2030 targets to support alignment. And beginning in 2025, states do have the option to select our national outcome measure as a separate state outcome measure if they would like to set annual targets for their annual application and annual report reporting that I'll talk about a little bit. How do national outcome measures get used by the state Title V programs? They're very, very important. As I said, these are sentinel indicators. And so we provide the data to help assess trends over time and seminal indicators of health. It helps states compare their rate to other states and the US overall to sort of understand where they fall in terms of this outcome measure. It helps to identify disparities in the outcome measures, but because we provide stratified data by a lot of different demographic variables, including race, ethnicity, urban, rural geography, insurance type, income level, etc. Looking at national outcome measures helps states determine priorities for their programs, and eventually it helps assess their progress on any efforts they've made to try to improve that outcome measure through the state performance measures or the national performance measures. NOMs can also be used by the public outside of the Title V programs. The data is available publicly, so therefore it helps inform annual review of Title V programs and helps support recommendations for strengthening the program. It also informs public input that you might want to give on Title V application annual reports. National outcome measures also help to improve the visibility and prominence of an issue to ground conversations with local, state, and national groups, much in the same way that you might point out that this is a Healthy People 2030 objective when talking to those you're hoping to have a conversation with at the state level or the national level. It also helps to point to the fact that this has been selected as a Title V national outcome measure. So moving away from our outcome measures, I wanted to point out how what our national performance measures are, which are really the working metrics that we use a lot on the day-to-day basis in Title V. With this guidance, we've updated the Title V performance measure framework for the first time since 2015. We added new Title V national performance measures, and we also created a new set of measures that's called standardized measures that states can use to select state performance measures. So here you can see that we have to work across the life course, and we have several different population domains. So we have women and maternal health national performance measures, perinatal infant health measures, child health specific measures, adolescent health measures, as well as children with special health care needs. So our legislation and our mandate is quite broad to improve the health of the MCH population as a whole. And under each population domain, we have national performance measures that are specific to those domains. And the different colors of measures are also different mechanisms by which the national performance measures is intended to improve the national outcome measures. So the gold are measures that we use to improve the clinical health system. The rose color are measures that we are using to measure how well we are improving health behaviors that might improve the national outcome measures. And then in gray are new measures called reflective of trying to improve the social determinants of health around these different population domains. So each of our national performance measures must be associated with at least one or more national outcome measures. And I have underlined and bolded the national performance measures that we have identified as being associated with the new national outcome measure on stillbirth. So under women and maternal health, we have reducing discrimination during perinatal care and reducing housing instability among pregnant women. And then under the perinatal and infant health domain, we have improving access to risk-appropriate perinatal care, and the same to social determinants of health related measures, because those have significant perinatal and infant health outcomes as well, or are associated with perinatal and infant health outcomes as well. As I briefly mentioned, we have some other standardized measures available to states starting in 2025 that they can select as state performance measures. So any priority need that they identify in their 2025 needs assessments needs to have an aligned performance measure. We hope that our national performance measures align well with their priority needs, but if they do not align well, then they must select and create a state performance measure. And these standardized measures are measures that states can use to create a state performance measures if that's appropriate for their priority needs. So we have a standardized measure around well woman visit, early entry into prenatal care, smoking during pregnancy, and drinking during pregnancy. So these aren't the only standardized measures available, but they're the ones applicable and related to women and maternal and perinatal infant health outcomes that might improve, impact stillbirth. So how do all these things fit together, and how do Title V programs use the outcome measures and the state performance measures? This is a little workflow to give you a sense that goes well nicely with that sort of cog figure that Dr. Payne showed before of what Title V does. The 5-year cycle that Title V works from starts with a 5-year needs assessment, and the next one that will be due is in 2025. So states are actively working on their 2025 needs assessment. From that needs assessment, they use that data to select 7 to 10 priority needs. And then per our guidance, they have to select 5 or more national performance measures, 1 in each population domain, plus any applicable state performance measures. And then once they've done that, they can develop their 5-year state action plan, which is really their logic model. What are the evidence-based strategies that they are going to use to address their priority needs and help make progress on the performance measures that they've identified? And then each year in the 5-year cycle, they have to submit an annual report that details everything that happened in the previous fiscal year, as well as an application year narrative that details everything they're going to do on the next fiscal year. So this is their annual reporting on their state action plan, how well they've done, and then what they plan to do in the upcoming year. So this is done in the interim years. And then each year after they submitted that annual application and annual report, we have an annual block grant review where expert outside reviewers review their application and annual report and give them feedback on how to strengthen their program. So just to give you a sense of what this will look like when we start providing data to the states on the national outcome measure. The first opportunity to look at the stillbirth data for the national outcome measure will come in April 1st, 2025. I collate all of the national outcome measures, the national performance measures, and the standardized measures from those different federally available sources into a FAD resource document and spreadsheet that includes the data and all the stratified data for at least the last few years for each of our measures. So this, I'm giving you an example of what it will look like. This right now, I'm showing you a filtered view of our national outcome measure on severe maternal morbidity. So I'll use the same measure throughout to show you what it will look like for stillbirth. So this is just a spreadsheet. You can filter it to look at different measures, to look at different states or regions, and to look at across time and years and different demographic stratifiers. This is the most comprehensive data that you could access each year, and that is usually released on our website with the link here, the FAD resource document page, April 1st of each year. And then after that, all that data that's in that spreadsheet actually gets inserted and entered into our Title V information system, which is our grants reporting platform that states have access to help create their annual application and annual report. So all the data from that spreadsheet is inserted into TVIS, and therefore it pre-populates for the states into their Title V application annual report form. And the NOMs and NPM data are reported in Form 10. And this is a screenshot of what it looks like in the print version or the PDF version of this application annual report. Again, this is for severe maternal morbidity. It provides a multi-year trend. It doesn't have all the same data. It doesn't have the stratified data. It doesn't have the data for all the states or for the US, but this is just for one state's data. And that's what it looks like. So some of you who may have looked at a Title V application and report will recognize this. Another way that the data will be accessible and presentable is through our TVIS web reports. These are updated every November. So for stillbirth, you will see this in November 2025. We take the data from those application annual reports and use that to populate trend charts on our TVIS webpage that anyone can look at, download images of, as well as looking at it in a tabular form. So this is just a trend chart for our severe maternal morbidity. So every year I add a new data point and it builds onto this trend chart that you'll see this. This is for the overall national rate of severe maternal morbidity. You can also, on our website, use a drop down to select any particular state that you want to look at as well. Another view that you can get from our website is the stratified data. So this is very new as of 2 years ago that we are providing the stratified data that's in that bigger spreadsheet on our TVIS website. And here you can select different demographic stratifiers. Here I've selected race, ethnicity, and then you can look at the data by all the different sub-stratifiers that are available for that stratifier category. So race, ethnicity has Hispanic, non-Hispanic, American Indian, Alaska Native, Asian Pacific Islander, non-Hispanic Black, non-Hispanic White, and other. This will vary based on what stratifier data is available for each measure. So just take note, you might not always see the same categories of things that are available. And we've only started displaying the stratified data since 2019. So that's why there's not previous years available. Next year, you'll see data for 2021 added to this. So that's everything, that sort of how we are going to be using the national outcome measure, how it will be presented, how you can access the data in the coming year. Here's my contact information, and we'll get you Shirley, Dr. Payne's email address as well, but I'll send it back to Emily now.
Thank you so much, Dr. Uesugi and Dr. Payne, for your presentation and for your time today. We're so grateful for your expertise and for sharing that knowledge with us. We will come back to HRSA outcome measure, the stillbirth outcome measure, shortly and take time to read through any questions that you might be placing in the Q&A. But first, we just want to share a little bit about how you can improve stillbirth outcomes in your county, your community, or your state. So let's put this outcome measure into action. Our life-saving stillbirth prevention program started in Iowa and has had tremendous results that we want to replicate in your state and your community. So Count the Kicks is a highly effective, evidence-based stillbirth prevention program. It's a proven early warning system for moms. We've saved lives in 36 states and in 6 countries so far. I want to be clear that this presentation is not an endorsement of Count the Kicks by HRSA. We are simply here as a nonprofit organization that works with state and county health departments, PQCs, health systems, and a lot of additional partners to prevent preventable stillbirths with a strong desire to help end the stillbirth crisis. So how do you prevent stillbirths? It's a question that we get a lot. There are multiple studies that show how a change in a baby's movements in the 3rd trimester of pregnancy has shown an increased risk of stillbirth. In fact, the study that's cited on this slide, this case control study, compared individuals who had experienced stillbirth to people with an ongoing pregnancy or live delivery. It showed that those who had a stillbirth were much more likely to have reduced fetal movements in the preceding 2 weeks from the stillbirth. So this is why we say a change in a baby's movements in the 3rd trimester can very much act as an early warning system. I'm sure it's why the CDC and its Hear Her campaign lists a change in a baby's movements as one of its 15 urgent maternal warning signs. And so if addressed properly, and if a baby is truly in distress, an intervention can happen and lives can potentially be saved. We've seen this. So think of it like this. We tell adults a droopy face could be a sign of a stroke. Chest pains could be a sign of a heart attack. A change in a baby's movements can be a sign that a baby is in distress in utero. If detected soon enough, in many cases, we can have drastically improved outcomes and save lives. Not in every case, but in many cases we can. Research shows that pregnant women should be educated about awareness of fetal activity and reporting abnormal activity to health professionals. You can read loads of research about fetal movement monitoring, including the one cited here, on our website, countthekicks.org. Chances are, if you do not have Count the Kicks in your state or your community, providers may not be educating on this early warning sign or telling parents about the importance of paying attention to babies' movements in the 3rd trimester. Time and time again, we hear from moms across this country who have recently endured a stillbirth, and they reach out to us and they say, "Why didn't I know about you?" Oftentimes, they've even spoken up to their provider about this early red flag and change in movements, but their provider maybe didn't handle their concerns properly or in time. Stillbirth, as you saw, is a significant issue for society. Birthing people and their families, as you saw at the beginning, 1 out of every 175 pregnancy ends in stillbirth. But we do know that it can be prevented in many cases. In fact, research shows a minimum of 25% of stillbirths are preventable. And this is where Count the Kicks comes in. Our public health program, as we mentioned, started in Iowa more than 15 years ago. We designed it to be bright and empowering, something that expectant parents would want to pick up and learn more about. Printed educational materials are the core of our campaign. Years of data show proof of Iowa's stillbirth rate declined dramatically over the life of our program to the tune of 1% every 3 months for an entire decade. Shout out to our key early partners, the Iowa Department of Health and Human Services, for doing true systems change work alongside us in order to see these significant results. So let's see those results on a chart. If you take a look at this graph, the red line at the top represents the national stillbirth rate, and the teal dots and trend line beneath it is our Iowa rate, starting in 2003 and then going through 2022, the most recent data year we have on record. Where the teal dot meets the red line at the top is 2008, the year our campaign started, a soft launch in our state. You can see the trend line down from there. One important note is that the majority of the US has remained pretty stagnant, whereas Iowa's rate has decreased. Of course, there are some years that it fluctuates, but it's important to look at data yearly and on averages. A large syphilis outbreak or many other outside factors could cause a spike. We are currently at a 70-year high when it comes to congenital syphilis, which can impact stillbirth, of course. So one important takeaway from this data is that in Iowa is that when risk factors, things like smoking rate and obesity rate have increased in Iowa during this time frame, our stillbirth rate still saw a steady decline, while other states without movement monitoring programs have remained relatively stagnant or have increased. The source of this information is the Iowa Department of Health and Human Services, as well as CDC and National Vital Statistics. The link to this Iowa data is included where it says source at the bottom of this slide. And so our results have been published in BJOG, the British Journal of Obstetrics and Gynecology, as well as AJOG here in the US. You can read more about the research by clicking on the QR codes on the slides. The BJOG research examines those Iowa results, while AJOG shows how Count the Kicks helps moms bond with their baby during pregnancy and also is proven to help lower anxiety among moms during pregnancy as well. Our program was named a best practice by the Association for Maternal Child Health Programs, AmChimp Innovation Station in 2021. After a thorough scientific review, the leading maternal health association in the US, of which many of you are probably members, determined that our program meaningfully engages stakeholders at all levels of practice. It ensures improving health equity is an integral component of our work and program sustainability and has been externally validated by another entity. Not just in Iowa have we seen success, but in other states as well, and then replicated with similar positive results in another context. So we are currently partnered with A1 on a project to standardize how providers respond to a complaint of a change in fetal movement from expectant mothers in the third trimester. So A1 is the Association of Women's Health Obstetric and Neonatal Nurses. It is the leading OB nurse association in this country. A1 President-elect Rose Horton sits on our organization's board of directors, and the protocol will likely be complete early next year. It was precipitated by too many moms reaching out to organization after the stillbirth of their baby with stories of potential dismissal from their providers or providers not knowing how to handle the warning sign. You can scan the QR code on your screen to read their practice brief on reduced fetal movement that was published earlier this year. That brief sheds light on various aspects of fetal movement, emphasizing the need for education during pregnancy and interventions for both mom and baby if a baby or mom is in distress. So there are some proven benefits beyond stillbirth prevention with Count the Kicks or fetal movement monitoring in general. Through countless stories from doctors and moms, we know that Count the Kicks not only is a highly effective tool for stillbirth prevention, it is also helping moms identify issues that crop up that are putting their own health at risk and in danger. Count the Kicks is proven to help identify pregnancy complications that threaten the mother's life. We've had a lot of moms write to us and let us know that a change in their baby's movements alerted them to preeclampsia that had gone undiagnosed, or things like the start of a placental abruption, the start of a maternal fetal hemorrhage, which could be devastating for both baby and mom. And so Count the Kicks is proven to help identify things like those pregnancy complications, but also to increase gestational age for baby and reduce NICU stays. You can read more research on this in the link on the screen. A recent meta-analysis analyzed data from 18 studies and found that encouraging awareness of fetal movement may be associated with reduced adverse neonatal outcomes, such as decreased rate of NICU admissions, without an increase in rates of cesarean birth or induction. In addition, you should know that Iowa's C-section birth rate did not increase and has not increased in the 15 years of Count the Kicks in our state. So here's why we're doing this. This is Mabel. I want to introduce you to Mabel. Her mom wrote into us to let us know about her safe arrival, saying, quote, "The only red flag there was a problem with our pregnancy was my daughter's change in movement. I am so grateful I had concrete data from the Count the Kicks app, which gave me knowledge and that something was off and the confidence to advocate for myself and my baby. All moms deserve to have this knowledge so their babies can have a healthy birthday too." So here's how you can implement our evidence-based stillbirth prevention program in your state. I'm not going to go into every detail because we are limited on time, but I wanted to share a little bit more about our turnkey solution. This is the life cycle of partnering with Count the Kicks and our nonprofit Healthy Birthday Inc. First is the planning stage. And we have an a la carte offering of tools and resources we know work, are proven to work, and you can choose which resources to implement based on the needs of your state and your community. Things like health worker trainings, educational materials, community baby showers, adding additional languages to the Count the Kicks app or printed materials, billboards across your state, and more. The second phase is to launch and therefore implement Count the Kicks in your state. We do this by notifying providers and systems who work with expectant parents, community-based organizations, letting them know about this life-saving program. We do this through a press release, letter, email, launch webinar to get the word out in your state about our program and our partnership. Finally, we have the data and reporting stage. Each quarter, we provide vital data back to you and your team on things like the number of app users who are turning to Count the Kicks to monitor their baby's movements in your community or state, the number of how many people from your state are visiting our educational website for information on fetal movement monitoring, and then data behind our communication efforts, such as social media engagement and webinar attendee numbers, baby shower attendee numbers. This data helps us get a clear picture of the reach of Count the Kicks in your state and the success of it. Our goal, again, is to replicate the strong stillbirth rate reduction that we have had in Iowa in your state. The most important way we do this is by sharing those printed Count the Kicks educational materials with every expectant parent in your state and your community. We offer posters that you see on the screen, brochures, app download reminder cards in multiple languages that can be co-branded with your logo. We want people to know that you have invested in this to help improve their life and improve their outcomes. Right now, if materials are not free in your state, let's say if you live in a state like Oregon, for say, that is not a funded partner, they are available at low cost, but your investment would make these free and remove a significant barrier and access to this important life-saving education. We also have the ability to translate all of our printed materials into languages that meet the needs of your community. We recently partnered with the Maine Health Department, for instance, and I believe we translated into, I believe, 5 additional languages in order to meet the needs of their community. So after receiving a comprehensive contact list from you, this is where we start and how we start raising awareness. We're going to combine it with a provider list that we already have for providers throughout your state and health equity organizations, community-based organizations, WIC locations, federally qualified health locations, things like that. Count the Kicks is going to conduct a mail campaign to providers and community-based organizations announcing the launch of the program in your state. And again, it's our staff, our organization doing that legwork. Your staff does not have to do that. This mailing is going to be included. It's going to include a letter drafted by us, but edited and signed by a leader within your organization. You can see that on the upper right-hand part of your screen. That letter is going to share the evidence behind the importance of fetal movement monitoring, an empowering message behind the importance of fetal movement monitoring, an empowering message to implement the program within their practice, their birthing hospital, and then the goal to prevent stillbirths in your state. We also send free sample educational materials and clear direction on how to order those materials online. Our staff will mail the announcement letter and those sample materials. Again, you don't have to do that legwork. Using a comprehensive email list of traditional and non-traditional providers in your states, we also send a co-branded email to stakeholders throughout the state announcing the partnership. It's going to highlight your investment in this work. It's going to allow recipients to click directly through free resources available to them, and then takes them directly to how to order those free materials online. It'll also give them free digital tools that we will provide that will help them implement Count the Kicks within their work. So with health equity at the center of our work and a health equity team on staff dedicated to reducing racial disparities that persist and bridging the gap in rural areas, we offer things like kid counting wrist bracelets that you see on the left side of the screen for moms without smartphones or moms without great access to broadband or strong internet. We can also do things like host virtual baby showers that are empowering and educational. You can also see those badge reels, pens that you can have in provider offices to help spark the kid counting conversation. So this is our hallmark tool. The free Count the Kicks app is available in 21 languages. It is a tool which allows moms to get to know their baby's normal movement pattern through daily kick counting sessions, movement monitoring sessions in the third trimester. Now, this app is already free to moms across the state and across the globe. And there are additional ways, though, that we can tailor the app to help meet your goals. For instance, several of our state partners have implemented a social determinants of health survey within their state that is served to expectant parents in key zip codes throughout your state. And if those parents indicate that they need help in areas like food assistance, access to an OB, or childcare, they will be directly linked to resources within their zip code. We do not share or sell app user information. We do not have any marketing of products within this app. We are simply a nonprofit organization that wants moms to use this in the third trimester as a really valuable tool to monitor their baby's health. So these are the states that currently implement our program, either through state health departments, managed care organizations, PQCs, or other funders. This is where we have funding to help have some of this key education getting in the hands of systems and moms and partners. So in 2022, the Title V Block Grant, as you saw mentioned earlier, impacted 93% or nearly 3.5 million pregnant women in the United States. But to date, funding is not being leveraged to the fullest extent to prevent stillbirth. In our opinion, fewer than 20 states or territories are using Title V Block Grant dollars on stillbirth prevention activities, leaving American families unnecessarily vulnerable to preventable stillbirth. Of the over $2.6 billion or so currently available to states in the Title V Block Grant, it is estimated that less than $1 million is being currently used on stillbirth prevention nationwide. And we believe it's time to change that. If you're interested, here's a look at our current funding partners making Count the Kicks possible in states. So it's state health departments, but it's also other really valuable partners like health insurance companies or PQCs. So there are many ways that we can raise awareness. If you aren't a funding partner that's listed on here, we would still love to partner with you. Even if you have this in your state, there are many ways we can raise awareness together and save lives. And I should emphasize, without duplicating efforts. If we're doing one thing in a state like those co-branded materials, that's not something we're going to do with an additional funding partner. That is dedicated to that first funder. But there are many other things that we can do to partner with you to raise awareness, like health worker trainings, billboards, community baby showers, a wide variety of things that we can do to raise awareness and improve outcomes. It's going to take all of us. It is going to take all of us to solve the stillbirth crisis, and we invite you into this work. So just in closing, here are some commonly asked questions about launching Count the Kicks in your state. Funding mechanisms in states, we see states either using their Title V Block Grant dollars solely to launch Count the Kicks, or they may use a recent grant they received related to improving outcomes for moms and babies. It might be a maternal health tech grant, or they get creative and pull funds from a variety of areas such as MICFE, MCH, oral health, or rural health funds. We are a sole source opportunity. We are the only organization or company in the U.S. that created these kinds of evidence-based tools and resources to educate and empower pregnant women to track their baby's movements in the third trimester. We're the only entity to provide a continuum of this kind of stillbirth prevention education to both moms and health providers. The totality of what we offer, from educational brochures, posters, app download reminder cards, kick counting wristbands, the free Count the Kicks app, free online digital tools, including CE trainings, how-to videos, childbirth education lesson plans, training for providers, and more, is unmatched in this country. We are a turnkey operation, and so the time that your team will need to contribute to the program is minimal, but it's powerful. We take care of all the distribution of those materials. We host webinars, the health worker trainings, but we ask that you contribute in key ways, like inviting us to maternal health conferences, to host a table or exhibit, or to speak. We raise awareness among your provider networks and your networks about Count the Kicks and the free offerings that you have made possible. We look to you for connections and relationships that we may not have yet with key stakeholders, and then we take it from there. So, what should you do first? We invite you to learn more by attending office hours with our state expansion director, Sarah Coleman, and I, coming up on Thursday, June 13th. So, 2 weeks from today at noon to 1 p.m. Central. You can register to attend and chat with us by scanning that QR code on your screen or visiting that web address at the bottom. You're also welcome to reach out to me anytime via email. My email address is on the screen. So I'm going to go ahead and stop sharing. So let's get to questions that you have submitted, and I'm going to bring back our friends from HRSA and stop sharing. And let's go ahead and dive into some of the great Q&As that have been in here. And so one of the things that Carol Gilbert has asked in Q&A is, it says, CDC Wonder does not provide county level data for stillbirths. Many initiatives happen at the county level, so it's important to be able to measure things at that level. Will this change? And so, oh, I see. Dr. Payne, you've said here that we're unable to speak to CDC Wonder and any potential changes they're considering. So that's a good note. Carol, a good idea would be to reach out to CDC with that question and they can help. And then Dr. Payne, would you like to address the second question? I know you've addressed it here in the Q&A function, but she is asking about the potential underreporting of fetal deaths between 20 to 24 weeks.
Yeah, thanks, Emily. Yeah, I just think, especially just addressing it in the chat again, we do recognize the states, and jurisdictions do have just unique challenges, be it underreporting, the collecting of data, making sure that their, data is representative of all their population. So we do recognize that, we do know the states, undergo, their quality improvement activities. And so hoping that, they continue to do that as well as they continue to, whatever space, that they may be in, including for stillbirth.
Thank you. Appreciate that. And then what is the cost of the program to implement? Thank you, Alma, for that question. One of the things that the cost is based on, it's based on a couple of things. The most significant one is your birthing population. So our goal in every state is to reach every expectant parent 2 to 3, 4 times with Count the Kicks education. Research shows that oftentimes to get to behavior change or using the app in pregnancy, paying attention to your baby's movements. One of the things is that someone, has to see or learn about it multiple times before they actually take action, AKA monitoring their baby's movements. And so we try in that a la carte approach to have multiple ways that we're reaching expectant parents. And so, for instance, the state of California, it would cost a lot more in the state of California than in, say, the state of Idaho to launch Count the Kicks there. And so it is based on the number of expectant parents. So it's hard for me to say exactly what it would be in your state, but that is something that you and I can talk about. I'm sorry, Alma, that I don't know which state you are in. And so once I'd love to talk with you offline about what it might take to launch in your state, but just know that it is based on population. We can work within your budget as well. So a lot of states will say, I have $60,000 this year to pilot it with you. What can we do within $60,000? Some smaller states will come to us and say, I have $15,000. What can I do within $15,000? We will work within your budget and work within your goals. But one of the things that we've seen over the years is that once a state launches in that first year, oftentimes many of them come back with some additional funding in future years because they see the proof that it's working, they see that lives are being saved, and they want to expand and enhance the work that's already being done. The next question is HRSA considering supporting Healthy Start programs to implement Count the Kicks? I guess I don't want to put Dr. Payne on the spot, but we do work with Healthy Start programs, for instance, like in the state of Florida, very strong Healthy Start program there. And because the Florida Department of Health has launched Count the Kicks throughout the state of Florida, we are basically partnered through the Florida Department of Health, working with Healthy Start programs to implement Count the Kicks there. But I don't know if that's a question that Dr. Payne can answer or not.
No, I said, as many of you may be aware as well, they just, announced their new awards more recently. So they have 100 or over 100 awards that they have. And so I know that each of those applicants certainly write to the unique needs of their community. So they're able to determine it and work through what they feel may be best for the community.
Thank you, Dr. Payne.
Yeah.
I'm excited to be with the Healthy Start Coalition in Tampa in just a couple of weeks, helping train their health workers there. We have really strong partnerships with Healthy Start programs throughout the country. They're such a valuable, valuable program in this country. And then someone else is mentioning that Delaware has had a project for many years, Kick Counts. That's right, you absolutely have. There's no app associated with that. And then not sure if it moved the needle for stillbirth or premature birth. That's also something I'm not able to answer, but we could certainly look into that. Oh, Almost from New York, wonderful. I'm going to connect with you for sure, and I would love to talk with you more about stillbirth prevention work and goals that you might have related to that. Let's see if there are other questions that maybe I have missed.
Emily, I just wanted to add that I replied again in the Q&A regarding the county level data for stillbirth. My MCHB colleague just informed me that we're adding county level stillbirth data to our maternal and infant health mapping tool. And then I provided the link there, and that should be available mid-August.
That's amazing. Thank you so much. I see this is another example of when you go to HRSA and you ask, I just think you have been so thoughtful and so um, um, willing to if someone asks like, can we add this? You have just been so proactive in your approach, and that's just another example of how proactive you all have been, and so grateful for that work. Another question in the Q&A was, will we be able to see these slides? So yes, we will send these out. You will get them early next week at the latest, along with this recording. And so absolutely, you will have these. And let's see if there are any additional questions. There are some in the Q&A that have been answered that you can look through as well. And I think that we have answered all of them. So with that, we will say thank you and really grateful to Dr. Payne and Dr. Usugi for their time and effort that went into today and into the outcome measure. Oh, I see a raised hand. I'm not sure if I'm able to. Megan, our program director, is on this call. Is there a way, Megan, to hear her question of the raised hand?
Let me double check. Yep, I'm gonna allow you to talk, Chelsea, it looks like. You should be able to unmute now, Chelsea. And then it looks like, George, you also have, I'll allow you to unmute yourself as well if you have questions. Feel free.
Go ahead, George.
Hi, it's George. No, I hit that hand by mistake. I was going to the reaction section. I clicked too soon. Sorry.
Okay. No, thank you. Thank you. Perhaps that's what Chelsea did as well. I don't know. But thank you guys so much. Thank you everyone for your time today. And we look forward to working with you if this is something that you would like to expand in your community or your state. So we will let you go for now and just say thank you all so much for your time. Have a good day.